Welcome, everyone, to today's session of the Survivorship Series led by Abby Slate Champa. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate the Q&A. If you have any other questions or would like more information on resources and programs offered through the Blum, please visit our website, www.dana-farber.org/resource center, or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Abby.
Thank you so much, and thanks for joining today. As mentioned, my name is Abby Slate Champa. I'm a nurse practitioner in the Adult Survivorship Program at Dana-Farber, and I deliver care to patients who've had a history of cancer, a variety of cancers. But today I'm going to focus my discussion and talk on the survivorship care that we give to breast cancer patients. I wanted to just start off briefly by explaining the definition of how we view a cancer survivor. This is a person who has had cancer. That means that the definition begins when one is diagnosed and through the remainder of and balance of one's life. And that means there are different types of survivors, including those living with cancer and those free of cancer. And really, this is a term meant to capture a population of those with a history of cancer rather than to provide a label that doesn't always resonate with individuals. Survivorship care really isn't limited to one point in time. It does span from diagnosis to treatment, into completing treatment, or even on chronic treatment, long-term therapy, and then even at the end of one's life. So just as each person with the same disease is not treated with the same medical regimen, survivorship care is also tailored to the needs of the individual. And the needs vary depending on follow-up and supportive care. And there are different needs early on in survivorship versus later on in the care that we provide. U.S. cancer survivors are growing. In 2019, it was estimated that there were about 17 million cancer survivors in the United States. And in 2029, it's projected that we will have almost 22 million cancer survivors, really speaking to the fact that this is important care and that there are many growing cancer survivors. And this graph is to show you who those survivors are. The highest number being amongst the most commonly screened detected cancers in terms of breast cancer, colon cancer, and prostate cancer, but not insignificant numbers in the other diseases. In 2006, the Institute of Medicine and the American Society of Clinical Oncology took a look at cancer survivorship in our country and created this document called From Cancer Patient to Cancer Survivor, Lost in Transition. And the title really says it all. Their data found that survivorship care was neglected in terms of the cancer journey, and there were few guidelines in place regarding follow-up care. They also found that the providers that were tasked with caring for cancer survivors lacked education and training, and there was a lack of coordination between cancer specialists and primary care, which we know is a very important part of keeping our patients healthy. So why does it matter and why do we do this? First of all, it matters because we need to be able to detect problems that can be prevented, cured, or controlled. And second, we have to ensure that we aren't overusing or underusing medical resources. And neither is uncommon, and I'll explain what I mean by that. It's important to use evidence-based practice to care for our patients, and the care and survivorship really has been enhanced and helped by the research being done in the field. But the overuse comes into play when a patient, for example, may have a frequent breast exam, perhaps with me and their surgeon and their primary care provider and their gynecologist. And really, when a patient needs one breast exam a year and are having this done in a similar time frame by multiple providers. Alternatively, the underuse comes in when somebody doesn't have the follow-up they need to survey or assess for long-term complications. In our program, we're striving to improve the health and quality of life for patients living through and beyond a cancer diagnosis. And we do this by providing clinical care and education, counseling, and patient-centered research. And we do take a personalized approach to the follow-up, meaning we survey for the prior cancer, we're trying to prevent long-term issues, we manage long-term side effects. We do a lot of counseling on lifestyle and modifiable behavior, and we coordinate care for our patients when needed. Really, there are four major areas of focus in cancer survivorship when patients come to see us. We are, of course, surveying for one's prior cancer and new cancers. We look at the long-term and late effects of what the cancer treatment may have caused, as well as risks associated with that treatment. As I mentioned, there is a lot of counseling regarding modifiable health behaviors. These are things like diet and exercise, minimizing alcohol, smoking cessation, things like that. And we do coordinate care with other specialists when that is appropriate. The way that breast cancer care and the survivorship comes into play are in two main pathways. The first is a graduation from breast oncology at the completion of therapy. This could be if someone is on a long-term maintenance medicine like anastrozole or tamoxifen, and perhaps they're taking this for 5 or 10 years, or it could be for someone who didn't require those medicines and is completing surveillance after 5 years. This is when the breast oncology team deems appropriate to transition fully over to the survivorship clinic, and we will continue to survey in the way that the patient is used to. The other subset of patients that we see, and I will touch on this a little bit later, are the young and strong patients. This is a program embedded within breast oncology for patients 45 and under with a breast cancer diagnosis. And we do provide a consult visit early in their care, as well as full transition to our clinic when they complete their care, if appropriate. So the initial visit in survivorship is generally scheduled once active treatment or active surveillance within those first 5 or so years is complete. We spend a large amount of time in that first visit, almost 60 minutes, really to thoroughly review the history, and we update health and family histories, medications. We assess for any persistent symptoms related to the prior cancer treatment. We always perform a physical exam. For those that need imaging, such as mammogram or breast MRI, we will always order those. And we ensure that someone is up to date with age-related cancer screenings and vaccinations for their age. We also create a treatment summary plan, and I will explain what this is in a moment. And this is a document that we provide to the patient at their first visit, and we send to their care team and primary care provider. There are a lot of resources in survivorship that I will get into. Those with concrete medical needs, we will make appropriate referrals to our specialists. We will also identify any additional supports for healthy living in terms of tobacco cessation, sleep medicine, social work, and resources for wellness. The treatment summary plan is a document that the Commission on Cancer recommends giving to patients. And we have created a plan, and then I individualize it, and my colleague does too, to give to the patient based on their personal history, how we will survey them, reasons to call us, recommendations for healthy living, and resources that we have available both online and in person. It's a multi-page document. It doesn't replace the medical visit. In fact, our note that you can see in your chart is different than this. And it really is meant as like a record keeper. And we give you a copy and we send this to your primary care provider so they can also see this transition in your care. Follow-up visits are generally annually with any appropriate imaging. That is also when we do our physical exam. But of course, we'll see patients for symptom-driven visits as needed. If you're having any complaints or concerns, new symptoms, we will see you. The large bulk of the care that we give is around the psychosocial experience following a cancer diagnosis. And there certainly can be emotional challenges faced in survivorship, and I will spend a few minutes talking about this. It's not uncommon for people to feel a mix of emotions following completion of therapy or while on long term maintenance treatment. And there are some reasons for that. And it's important that there's a close coordination between our providers and mental health providers because of this. Sometimes medications are useful as well as lifestyle management, and we try to create the best support we can depending on the individual's needs. But the emotions surrounding survivorship care are complex, and not feeling physically well or at your best can affect how you feel mentally as well. So some patients that we see are still experiencing some long-term effects of treatment, such as joint pain or muscle aches, maybe fatigue. And while the physical symptoms can be annoying and long-term, and we can address those through different interventions, it can also add to a component of changes in mood in terms of anxiety and depression. And following completion of treatment or being on long-term maintenance can also come with life changes. Some patients express to us that they find it challenging to return to a job that they may have left when they were diagnosed, or they find it daunting, the idea of going back to work. They sometimes mention changes in relationships with friends or loved ones, although those people in their life are trying to be supportive by telling them that they look great and that everything seems so wonderful now. The patient may not feel as great as they look, and the patient's reality doesn't always match what their loved ones and friends are saying. There can also be some strain or loss of relationships due to stress of going through a cancer. And lastly, and this is something that I speak with my new patients about all the time, is that coming over from breast oncology to the survivorship program, there can be a mix of emotions. This can be in the form of fear or feeling like they're losing the team that they trusted. It can also, though, alternatively be one of happiness and joy, knowing that they're entering this new phase of surveillance. Usually, in my experience, it's a combination of both. And being followed in the survivorship program doesn't mean that somebody is losing their prior team. I explain this as that someone is gaining more oncology team members to continue to survey and care for them in whatever way was meaningful and needed for their care. The psychosocial impact of cancer is, as I mentioned, very prominent in the survivorship program because we know that studies have shown that almost up to a third of patients will experience some form of psychological symptoms. And this can be in the form of anxiety or depression, but sometimes people still note some cognitive changes. Perhaps they had some fogginess with their chemotherapy, or they're finding it challenging to re-engage in their professional life or their social roles or in their personal relationships. The chemotherapies and the medications we give can certainly affect sex hormones and libido, and that can be a challenge to intimacy. There can be some concerns over one's body image. Some patients do feel grief and loss over the life that they had before their diagnosis and the way that they feel about their life after a cancer diagnosis. Other patients, though, feel an increase in spirituality and hope having gone through this process. And there are some patients who are dealing with feeling guilty that they're on a maintenance medicine or their cancer has been cured when other people in their lives who are patients are not in the same situation. There are challenges for sure in survivorship in terms of delivering mental health care. Sometimes patients feel a stigma about asking about mental health care services, or they're not familiar with what services are available. And because we practice are in such siloed styles in modern medicine, sometimes patients don't even know who to ask or who to be referred to. And we do try and help in those regards. Besides medication and therapy, there is a place that's important to mention regarding integrative medicine, and I will get into what can be offered at Dana-Farber, but we do have integrative medicine through the Zakim Center And there is some data specifically regarding anxiety and depression in using different modalities in integrative medicine, both during active treatment and afterwards. And I did want to touch on this as so many of my patients have benefited, and I do refer them to the Zakim Center for these therapies. During active treatment, integrative medicine interventions for anxiety have been things like mindfulness, yoga, hypnosis, relaxation therapy. These are things that can be offered through some outside providers and through Zakim. In terms of post-treatment, again, mindfulness and yoga have been shown to be useful for anxiety, as well as acupuncture, Tai Chi, Qigong, and reflexology. In terms of those with feeling mood changes during active treatment, again, interventions in mindfulness and yoga have been shown to be useful, relaxation therapy, music therapy, and reflexology. And post-treatment, again, similarly to anxiety, mindfulness, yoga, Tai Chi, and Qigong have been shown to be helpful. But it goes without saying that people experience physical symptoms as well as emotional symptoms. And I did want to touch on for the population of patients who are diagnosed with a hormone-positive breast cancer and are taking long-term medicines like tamoxifen or anastrozole or letrozole. These are 5, sometimes 10 years of therapy, and living with physical symptoms can be wearing both physically and mentally. I've noted and read the most common side effects that patients report to us. But certainly it's important to think about all interventions that we can help in patient care in order for our patients to be able to stay on these medicines for the most benefit. And I did want to note that in a 2018 study looking at acupuncture, that those who received acupuncture versus those that did not did have improvement in their joint pain. In the survivorship clinic, a lot of what we talk about is long-term surveillance and ways to keep our patients healthy through cancer screenings. And long-term surveillance means that we're looking at the prior therapy that someone received for their cancer, and we're talking about any risks associated with that treatment or any long-term management of their symptoms. So I did want to touch on the most commonly discussed topics with our patients. The first being breast radiation. There is a low risk of skin cancer within the margins of the radiation field. And again, low risk, but we do recommend our patients to have an annual dermatologic screening for this reason. Additionally, as a side note, we recommend a full body screening for dermatology purposes for general skin cancer. But specifically in regards to the radiation, this is about the area on the breast that was radiated. When we're doing our physical exam, we are also checking the breasts and the skin for any abnormalities. For those that may have received anthracycline chemotherapy, and this is a drug like adriamycin, also called doxorubicin, or for those that know this as the red in color chemotherapy, this drug, when you're receiving it, can affect the heart, which is why there are echocardiograms done at certain time points when you're receiving this treatment. After this treatment is completed, and in our clinic, many years out from that treatment, we want to ensure that someone is living in the most heart-healthy way possible, getting enough exercise, and we do recommend 90 to 150 minutes of cardiovascular exercise per week. We recommend minimizing alcohol, not smoking, and to have your primary care provider check your cholesterol once a year. This is because there is a low risk of an arrhythmia, which is an irregular beat of the heart, or cardiomyopathy, which is damage to the diseases of damage to the heart muscle that can lead to heart failure. While this is extremely rare, we ask every year in our visits about any new cardiac related symptoms. As I mentioned, emotional support in the survivorship clinic is something that is touched on quite a bit. We have a social worker as well as resources to help patients find individual counseling, possibly closer to home. Sometimes we do feel that recommendations for medications are useful, and this can be prescribed through a primary care provider or a mental health provider. We also help patients cope with vasomotor symptoms. This can be hot flashes, weight gain, vaginal dryness. The medicines used to treat breast cancer can cause these. Also, those who may have been entering menopause and then given these medicines may have increased symptoms. And so there are both medications and lifestyle management that we can help in terms of hot flashes and vaginal dryness. We know that some vasomotor symptoms become intolerable, and therefore we use the Brigham and Women's Menopause Clinic to help mitigate long-term side effects that are really challenging. Sexual health can also be affected by cancer treatments in terms of the sex hormones, and we do offer guidance for products for patients to use that are safe for our patients. And we also have 2 sexual health therapists to see individuals or couples. I did want to take a moment and talk about secondary cancers. Sometimes we see this in the survivorship clinic. Sometimes, such as with the radiation, we see a skin cancer caused from the radiation. This is extremely rare, but secondary cancers do occur. And while we don't know exactly the mechanism of why when one has had a cancer, they go on to have a second cancer, we do know that lifestyle behaviors and screening for cancer really matter. And we ensure our patients are up to date with screening for their age as part of their health maintenance, asking about colonoscopies and pap smears when appropriate. We also know that healthy lifestyle is so important in terms of mitigating other medical issues or putting one at risk for a secondary cancer, such as obesity. The care that's delivered outside of the annual care that I give and my co-NP give are done through our specialists. And I did want to take a moment to explain briefly what we have in our program. For those who may have had a challenge or a medical issue unmasked by their cancer treatment, we have specialists in cardiology, nephrology, and endocrinology. And we will refer our patients to these specialists in the survivorship clinic for any long-term issues that may come up. We also offer oncofertility, which I will touch on briefly in a bit. We have a provider who sees our patients who are 65 and older, who may have a complex medical history or maybe many medications and overlaying their cancer history, and it can get complicated. And she will see patients and can sometimes act as primary care for them as well. We have a nutrition and exercise counseling program through the Integrative Medicines Center at ZACM. We offer sexual health, as I mentioned, and that is for individuals or couples. We have a sleep medicine program, which offers cognitive behavioral therapy to sleep. And our social worker offers tobacco cessation as well as psychosocial support. So just to put a few faces with names as to who is giving the care, this is our core team, including our director and medical director. We also have a nurse navigator, Carrie Riding, who helps to triage patients, and we have our social worker, Karen Morales, who I mentioned also does tobacco cessation for us. Our physician assistant, Laura Garber, does care for our gynecologic cancer survivors. And Dr. Larissa Nekladov is our onco-generalist with a primary care background who sees complicated patients who may have had a childhood cancer who are now adults. And myself and Mary McKenney share the load of caring for all the other patients. We see all the breast patients in addition to the other cancer histories. Mary is at Longwood and I am in Chestnut Hill. Our cardio oncologists are the 4 clinicians on the top of the screen, and our onconephrologists are below them. In terms of our sexual health program, I did mention we have 2 sexual health therapists in Dr. Chevalier and Dr. Bober. We have a gynecologist, Dr. Falk, and for men's health in urology, we have Dr. Catherines. As I mentioned, we do oncofertility, and I will touch on that in a moment, but we partner with Brigham and Women's Reproductive Endocrinology, and Dr. Ginsberg helps to lead that. Sleep medicine and through cognitive behavioral therapy is with Dr. Zhao. Dr. Shea sees our patients who are 65 and older in oncogeriatrics, and Dr. Nelson is our oncoendocrinologist. So in terms of oncofertility, I just want to mention this. This is a role that I play in our department as well. It is a 2-pronged process, usually occurring before someone embarks on treatment and is wishing to discuss fertility risks from that potential treatment. And I will conduct a phone visit with that person and determine if they would also like to be seen by reproductive endocrinology to discuss fertility preservation and potential IVF in the future. We also service our satellite, and there are 6 satellites at Dana-Farber now. Mary and I do a virtual one-time clinic for anyone who's about 6 to 12 months after completion of therapy in the satellites, but we do see a variety of timeframes. It can be years out. This is a way to offer our resources that we're able to offer to our in-person patients. And we see them virtually because they are continued to be followed by their oncologists at the satellites. I did want to now take a few moments to talk specifically about the Young and Strong program that I mentioned at the beginning. This is an embedded program within breast oncology. The needs of the young patient with breast cancer for those 45 and under are introduced in our Young and Strong program. And the way that we do this is that Mary or I will have an initial visit with these patients to introduce them to the concepts in survivorship. And the idea being that we want to add another level of support, another layer of support to this unique population. And they may have different needs than someone who is older. They'll stay with breast oncology for their duration of their surveillance or their completion of treatment, with the idea being that they eventually will transition fully over to surveillance in our clinic. The YES Survivorship Study is a mobile app and web-based supportive care and educational intervention for young survivors of breast cancer. And the YES portal provides patient-tailored education, information, and resources based on monthly assessments for managing physical and emotional symptoms. And the study participants can track their symptoms over time. They can access links to supportive care resources and connect with other young adults in a forum called YES Chat, all within the portal. And I just wanted to provide a screenshot of what that looks like. The Young and Strong program is set up to support the needs of the younger patient, both medically and physically, and survivorship is part of that design. And there are many other resources, as you can see here. I did want to draw attention to Embracing Young and Strong, which is a dedicated support program for young women living with metastatic breast cancer. There's also the Young Adult Program, which offers support and education and opportunities to meet young adults, and an online social networking group. There's virtual longstanding support groups with social work. For those with young families, there are parenting binders and kid packs, so quite a few resources for patients. In the survivorship clinic, we also follow breast cancer patients who carry genetic mutations. Sometimes our care is done in tandem with Dana-Farber genetics team, and other times they are in our clinic. And we ensure that all required screening is being done per the guidelines based on the genetic carrier status. We also always update family history at our visits to ensure that there isn't a role to re-engage with Dana-Farber genetics and determine if there are any new guidelines. And we do encourage family members to be tested. Besides the medical resources, as I mentioned, there are quite a few of psychosocial resources for our patients to enhance their health and support them along the way. Through the Zakim Center, there are many different program offerings. I've only listed a few here, including acupuncture and massage. There's also a 13 Weeks to Wellness program, which is a virtual nutrition and exercise program that my patients have found very helpful. We also have an exercise physiologist who can meet with patients virtually to design an appropriate exercise program if you're feeling like you need a jump start and someone to guide you. I always highly recommend my patients to try the 12 free weeks of exercise through the Livestrong program at all of the local YMCAs. For those that need referrals because of longstanding lymphedema, we do have a team of lymphedema physical therapists that we refer to. And for those who are looking to offer support to others after they've completed their own therapy, there is a program at Dana-Farber called One-to-One, which is in which a mentor is trained and then is able to reach out to patients who may just be beginning their cancer journey, and this is done by phone. There are other avenues for support, as I mentioned. For those struggling with challenging vasomotor symptoms, there's the menopause clinic at Brigham and Women's. There's also the Weight Management Center at Brigham and Women's, which is a place where they use medications for weight loss. We offer nutrition through the Zakem Center. And in terms of mental health guidance, beyond our social worker and our sexual health therapists, we have three important websites that we feel are useful to help find a therapist outside of Dana-Farber. And I did want to mention we're on the internet. You can access our website or use this QR code to see much more information regarding our program and all of the specialists I mentioned and what they can offer. And this is the website as well. And I thank you for listening.
Thank you so much, Abby. That was a very informative and important presentation. I also really appreciated all the helpful resources that you provided. So thank you so much. We did have a few questions come through into the chat. So the first one being, at which point is someone considered in survivorship? Is it after surgery or after completion of post-surgery medication?
I think that that's a perfect question. The definition would be right from diagnosis, but in clinical practice, it would be upon completion of therapy or surveillance. And usually that falls within about 5 years from diagnosis.
When is someone considered in remission? Is it after radiation or chemo, or after 5 years the tamoxifen is complete?
So generally speaking, medically a remission is not having evidence of cancer. So someone may, for example, go through a few surgeries because they need to have clear margins. They may go through some chemotherapy before surgery and onto surgery. They may go to surgery and then have chemotherapy, but really it's without evidence of cancer. So whenever that time is for that patient, that is considered a remission. In terms of surveillance, we feel that upon completion of therapy, that makes the most sense in terms of time coming to our clinic for ongoing surveillance.
What are some recommendations for long-term heart surveillance after radiation?
That's a great question. So generally speaking, for the person that receives radiation, there isn't a need to have ongoing echocardiograms or even EKGs because the radiation is generally fairly focal, meaning in one spot. But sometimes, rarely, we do see patients develop cardiac issues from their radiation because the radiation was given sort of close to the heart and they've gone on to develop a problem like atrial fibrillation, an irregular beat. But in the patient who does not have any complications in terms of their heart following radiation, and again, that is rare, we recommend lifestyle management, keeping your heart healthy, because actually things like family history as we age come into play more than radiation risk. So if you do have any palpitations, chest pain, anything like that, that would warrant seeing your primary care provider to start that workup. And then if that leads to anything, we can help in terms of oncocardiology.
There was another question about managing bone pain. Do you have any recommendations on navigating that?
So bone pain versus joint pain, those are two different things. So I'm not quite sure if it's true bone pain. Bone pain is a little bit different. It is hard to manage because our bones are not completely meant to allow things into them. So that might be a question very specific for that person. Joint pain, which sometimes people feel is bone pain, can be managed by a lot of different interventions. As I mentioned, acupuncture, exercise. There are medicines, of course, that can be used depending on the patient's medical history. But in general, those are the things we do recommend.
There was another question about the Live Strong program. If you could talk a little bit more about that, that would be helpful.
Sure. It's a fantastic program run through a grant. It's 12 free 12 free weeks of exercise at your local YMCA. You would call and tell them that you're a Dana-Farber patient, and they will tell you when the next session is running. It is a personalized exercise program, so although there may be a group, which my patients have told me has actually been helpful in terms of support, everybody is different in there, and it is personalized to you. And it also allows you to be a bit accountable to exercise, which is what we love, because you do have to go a few days a week in order to be part of it.
Perfect. Well, I really want to thank you again, Abby. And just as a reminder to everyone, that this session was recorded and it will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. So take a look there if you want to rewatch it. And really just thank you so much, Abby, for taking the time and answering all of our questions.
Thanks for having me.